Okay, great. Avi is always a hard act to follow. Thank you, Sherry and Bob, for having me. I'm delighted to be here, and I'll talk about, instead of a general body of work, I'll focus on a particular project that looks at a very specific set of questions. In particular, it's going to be looking at, does anybody in the room wear like a mobile health watch, one of those Fitbit? Okay, so a bunch of you. Okay, so maybe this will be of interest to you, because this paper or this project is really about understanding the incentives that people have to adopt these things, and more importantly, the consequence of adopting, right? So, and as I go along, I'll tell you more about this. This is joint work with Wei Bailey and Shikang Guo. So just to give you some background, as Bob was mentioning, at least for the last 15 years or so, my core interest has been in the mobile space. And since I haven't met most of you, I thought I'll pitch my book. The book is about monetizing the mobile economy, and it's really about trying to understand how this very atomic, granular data that's coming out of our smartphones and tablets, how do businesses use it, or how can they use it? And the focus of that book was really about monetizing in the form of advertising, marketing, digital payments, sharing economy, and so on. But what was missing in that book is an understanding of what does it do to sort of the non-business, more societal aspects of our economy, right? For example, education, right? So we saw during COVID that in some countries and in certain places where people had access to smartphones and computers, they were able to minimize the learning gap when schools shut down, whereas in other places they couldn't. But that's not a question that's actually been empirically quantified. Another example is healthcare. As Avi was saying, like AI is in a very, very early stage of healthcare, but one of the areas where AI is actually relatively more ahead is in these device level aspects. Okay? So this talk is really going to be focusing on a particular aspect of healthcare, which is mobile health that is driving a lot of our wellness, daily wellness behavior. Okay? So if you are one of those people who has one of those Fitbit or Apple Watches or Samsung Watches or any one of these things, you're probably familiar with things like how many steps are you actually walking, how many stairs are you climbing, maybe when you track your sleeping patterns and how many hours did you sleep, did you have deep sleep, REM, et cetera, et cetera. Turns out that this whole movement of quantifying yourself and quantifying your behavior is slowly but steadily really sort of making inroads in wide parts of our society. Okay, because there's a very different pricing tier. So you can go for the highest pricing tier, which is the Apple Watch, or you can have a much more affordable device like a Fitbit. At the same time, there's been a lot of acquisitions in this space. If you've been following this particular domain, Google started this with Fitbit and Synosys. An Apple Watch, by the way, if you've seen the latest one, it's pretty remarkable. It can actually even give you your blood oxygen saturation levels, which, the first time we started thinking about this, at least it was during COVID, right? Anytime you saw a patient with COVID, one of the first things you would ask is, what is your blood oxygen saturation levels? Turns out the newest Apple Watch can actually give you that, right? And so there's been a lot of advances in this combination of sensors and accelerometers and mobile computing. And so that is making this whole quantified, self-quantified movement even more ubiquitous. And that's really where we are coming at. So we are trying to understand a relatively simple question, which is, does the adoption of mobile health technologies, and I use this word to include, apps plus the devices, and what impact does it have on the healthcare outcomes of certain kinds of chronic disease patients? Okay? There are lots of different kinds of chronic diseases, right? So there's diabetes, there's blood pressure, cholesterol, and so on. And we're going to be looking at one particular kind. But not just looking at the short-term, behavioral change with wellness and lifestyle, but rather also more longer-term changes, right? So if things actually work out the way some of us think, which is, I adopt the device, I quantify myself, I monitor my behavior, I change my behavior, and eventually that should lead to some drop in my chronic disease symptoms in the short run, and then in the long run, it should lead to changes in hospital visits, hopefully a decrease in hospital visits, a decrease in doctor visits, and so on, and consequently medical expenses. Okay? So that's the question we're going to be looking at. And the way we do that is we do this through a large-scale randomized field experiment. Okay? You can't answer this question conclusively using observational data because there's going to be some self-selection in people who adopt these things. So that's why you have to rely on an experiment. So our partner here is based in Asia. They were the largest mobile health platform at the time we started working with them. They continue to be in the top 3 as of today. They specialize in all sorts of chronic diseases. In particular, they were the largest in the diabetes category, like type 2 diabetes. And so they had, at the time we started working with them, they had about 156,000 active users. And the way it works with the physician team is there is an in-network set of physicians, which is not different from what we have here in the US. You've got, if you subscribe to an insurance, you get access to an in-network set of physicians. And then there is an outside external physician network as well. And that's a much wider network. That has almost 10,000 physicians of different specialties. So you've got pharmacists, nurses, chronic disease doctors, you've got nutritionists, trainers, et cetera, et cetera. Okay? And so I'll talk about the app itself so that you have some color on how these things actually work. But just at the high level, the experiment we conducted was over a 15-month period. We have, in the final sample, about 1,070 diabetes patients. These are all type 2 diabetes. Okay? During the experiment, we have both information on pre-treatment through surveys and post-treatment. 5 months after the experiments are finished, we conducted a second set of surveys. Okay? And the surveys are always useful in understanding the mechanism as to what's really driving this sort of behavior change, right? And so we'll have to rely on a combination of experimental data and the survey. Okay, so this is an example of what the app looks like, which is not unlike most of these apps. If you have one on your phone, you'll probably be familiar with some of these features. So, for example, in the top, it gives you information about how many steps you walked. And there's also self-recorded information, like are you a smoker, are you a drinker? And then it'll give you information on how many steps you walked, how many calories you've lost, et cetera, et cetera. And what the app also does is, this particular app that we work with, it gives you a score, a personalized risk assessment score. That's where the AI and ML really kicks in. Okay? So the algorithms in the background are assessing a particular personalized risk assessment score for each individual based on not only their current behavior, but also historical data. So let's say you have some comorbidities in the past. You have the option to input that information in the app itself. And the other one is showing you an example where for type 2 diabetes, the patients in our experimental setup were required to upload their, they have to prick their fingers and upload their data every day. And so that's an example where by clicking on that, you can actually upload your data. Okay? Okay, so what is the app doing overall? So the app, it has 4 core sets of functions. First of all, it will do all the behavioral tracking. Okay, so this is essentially the usual suspects like number of steps, number of calories you've lost, etc. But the app also has the ability for you to input what's your diet like, what food you're actually consuming 3 times a day. You can do it in one of 2 ways. One is you can actually type in what you're consuming and with some expectation of what the amount is, the total morsel amount. Or you can take a picture of the food and then upload that, and the background AI system will actually make its own estimate of how many calories would that have actually gone in. Okay? The second aspect is the risk assessment score. This is what I was saying. This takes into account like 25 different factors about your concurrent physiological, biological data, but also your past history. Because for some patients with type 2 diabetes, if you have other kinds of comorbidities, it can be riskier than for others. The third is a Q&A forum. Here you can actually converse with the physicians and the pharmacists and the nutritionists, the trainers, so that you can get guidance from them. And then lastly, you have the patient community. This is a bit like WebMD, where you can actually talk to other patients like you. Sometimes you just want to ask questions to people who are suffering or going through the same process. Okay? So those are the 4 core elements of the app. Okay, so now the experiment. So what is the experiment design like? So as I said, that the core question here is, does the adoption of this mobile app lead to sort of both short-term and long-term changes in the behavior of these patients, right? So the short-term changes you're going to be looking at are a drop in glucose levels, okay, which is essentially driven by a change in, for example, your food, your diet, your nutrition, and your exercise, and your sleeping patterns. And the longer-term changes are going to be essentially driven by how often are you continuing to visit doctors or hospitals and so on. Okay, in terms of the actual design itself, so first of all, we have one group that has the C1 group does not have access to any of the app itself. There's two kinds of apps. One is the desktop, the web version of the app. The other is the mobile app. They both have the exact same features, right? The only difference is that one can only be installed on your smartphone, and the other has to be installed on, let's say, a laptop or a desktop. Okay?
Quick question.
Yeah.
Behavior data, that's solely what they input into the app, and nothing like from the IMU or anything from the sensors on the.
No, there's both. So, for example, from the sensors, you will get, your movement patterns, how many steps you walked, or how many miles you run, that sort of thing.
So you're getting steps and okay.
Yeah, it's both self-reported and from the sensors itself. Okay, so self-reported data would be, for example, your glucose levels, what have you actually eaten today, that sort of thing. Okay, so the second group is the one that has the desktop version of the app, right? And so the key reason we wanted to have the desktop versus mobile is, as is sort of very well known, mobile by because of the device itself, it gives you access to the app at any point in time, right? So the ubiquity of the smartphone is potentially a friction-reducing aspect of it, right? Because with desktops, you have to physically go near a laptop or a desktop to get to record your data. So the first treatment group is the version are the groups that get only the mobile health app. The second and the third treatment groups, here we introduce an additional, call it an aspect of this experiment, which is personalization of reminders. Okay. So initially, we started with thinking like we should just be interested in mobile versus desktop versus no app at all. But it turns out that there's a literature, and many of you are consumer psychologists and sociologists perhaps, so you probably know this better than I do. There's a literature about how nudges, personalized nudges, or the lack of personalized nudges can influence user behavior, right? There's been a lot of done work in marketing, but we wanted to examine this in the context of healthcare. Right? And so in marketing, for the most part, what we see is personalization tends to work well, that people respond positively, right? So like Avi was talking about targeted ads, targeted ads, for the most part, they work out. But in the context of this particular, healthcare space, especially with chronic diseases, there's no body of work that examines this particular question. So we thought, let's have that as well. So we're going to have three treatment groups, right? These guys only have the app without any reminder. These guys get a non-personalized, a generic reminder, and I'll show you an example of what that means. And then these guys get the personalized reminder, okay? Okay, so here's one example of, on the left is an example of a generic reminder. So as you can see, it doesn't address the patient by name, and it gives you almost like a public service announcement, right? So regular exercise at moderate intensity, is 3 times a week is good for your health, right? So it's almost like a PSA. But it's still a reminder. The guys on the right, that's where the personalization aspect starts to kick in. The first example over here, as you can see, is it will address me by my name, dear Mr. Ghose. You haven't been your active self lately. Let's say yesterday I didn't do any exercise at all. So today I'm going to get a reminder of this line, which says, yesterday you didn't work out at all, you have no activity. Today is, you might just want to go for a 30-minute walk. And, the rest of it is similar to the original message. Okay? And so that's what we wanted to examine, right? So do people who get these personalized nudges, are we expecting to see more compliance and sort of, more, positive gains from this? Okay, so first of all, I know there's a lot of numbers here, but given that it's a randomized experiment, right, we've got to do a bunch of checks that make sure that the 5 different groups are actually truly randomized in the sense that there's no systematic difference between them. So we looked at demographics, age, gender, income levels, and we also looked at baseline conditions. So good news was that they all work out. There aren't any systematic differences between the 5 groups. We also did other randomization checks as well. Okay, so let me start with the group level analysis. And you can tell the full story pretty much from here, but I'll get to the model in a minute. But here's what you should look at, right? So these are the 5 groups, the 2 control groups and the 3 treatment groups. The first 2 columns gives you the short-term results on glucose level changes, right? So the idea being patients who are adopting the app, if things do work out, you would expect to see a bigger drop in glucose levels, as in your blood sugar levels, okay? So all 4 groups over here, compared to the baseline, you see all these numbers are higher. So that indicates that these people are, in fact, benefiting from the app, okay? The same goes for glycated hemoglobin levels, right? That's another marker for type 2 diabetes. You can see that all these 4 groups are benefiting from that. And longer term also, you see, the groups adopting the app or having access to the app have, in fact, lower hospital visits, significantly lower hospital visits, and consequently, significantly lower expenses. Okay?
Clarification. Yeah. So the activity that they need to comply with is physical activity, or they need to take pills, or what do they have to do?
No, so all they have to do in the experiment is they have to, once they've signed up, they have to prick their fingers, right? And they have to upload their data, the glucose levels every day for the next 90 days, okay? And then it's up to them whether they sleep longer, they eat healthier, they exercise more or less. That's totally up to them. Okay, so that's now the second interesting thing is, remember I talked about personalization. So this is the group that is getting the non-personalized reminders. That's the personalized reminder. So what you see is the group getting the personalized nudge is actually underperforming than the group getting the non-personalized reminder. And in fact, it's also less effective than the no reminder at all. So that was the first, at least to us, it was a surprising finding that personalization, at least in this context, isn't working out the way we thought it would, which is that people are actually engaging in less compliance as opposed to more. Okay? However, in the long run, if you look at hospital visits and medical expenses, personalization does work out in your favor. In other words, the groups getting the personalized reminders are showing a long-term drop in hospital visits and a medical expenses as well. Okay? So this is again the group level analysis. In the interest of time, I won't walk you through all of the details in the model, but for the economists and the scholars in the room, this is a standard DID model, difference in difference. And that helps you capture the time series differences as well. So again, I just ask you to focus on the same 4 groups, the 1 control group and 3 treatment groups. Again, you'll see that compared to the baseline, all of the groups do benefit in terms of a drop in glucose levels. However, consistent with the ANOVA, consistent with the summary stats, the non-personalized group continues to show the highest level of drop in glucose levels, right? So because it's negative, a higher number means they show a bigger improvement, okay? So we ran a bunch of models to examine this, and it was the same result. So the next question is, what is really causing this what's really causing this result, right? So then we said, okay, all we see over here is that people who adopt the app are exhibiting or showing a drop in glucose levels. So that's the good news, but what's really driving that, right? So the next question is, let's look at actual activity, okay? So over here you have calories. The first column is calories. The second column is exercise time, then exercise calories. That's food calories. Then you have steps walked, sleeping hours, and weekly nights. Okay? So as you would expect, those guys who are adopting the app are in fact consuming fewer calories, which then shows up in a bigger reduction in glucose levels, right? So again, all 3 of them are statistically significant compared to the baseline, which means that these people over the 15-month period are making changes in their diet. They are taking less calories. They are exercising more, so sign is positive, right? So calories, both in terms of calories and time, they're exercising more, spending more time, and that also leads to an improvement in the chronic disease symptoms. The same goes for sleeping hours as well. As you can see, all of that is significant. The only one that didn't turn out to be as significant is whether you have late nights during the weeks as well. Okay? But basically what you're seeing is that the underlying mechanism that's driving this drop in glucose levels is a better diet, a drop, more exercise time, more exercise calories, and of course, longer sleeping hours. Okay? So that again, we did a bunch of other robustness checks, which I'll just skip in the interest of time. So the last question is, what was really going on in people's minds? Like we had to ask them, okay, so this whole personalization thing, which seemed surprising, like why aren't you guys complying with those nudges? Okay, so as we did the surveys, the first thing we wanted to examine is what do you actually like about the app? So that wasn't a big surprise. Most of them said, we like to learn about health, we like to learn about our real-time behavior data, we like to know about our personalized diabetes scores, doctor consultation, social network, all that is good. But here's where the kicker is. They said the reason we are inclined not to comply with the personalized messaging is, number one, sometimes it can be annoying and interrupting, but more importantly perhaps, is that we feel we are being judged. Okay, so the fact that you didn't exercise yesterday and today the app sends you a reminder. Okay, so and this is again where I was, I think there is this, and you guys can tell me, there's probably a literature in social psychology about people not responding well to judgment. Okay, I see some of you nodding. Perhaps there is. So I'd love to hear more, references to that. But that's really what came out in the surveys, right? So, we thought it would be other pieces like maybe some people complain about privacy. There were a few, but nothing in contrast to these two reasons. So, judgment and sort of annoyance was really sort of pretty stark. Okay. So just to summarize, I'd say what we are trying to look for over here and what we found is, number one, the good news is that there is now evidence that adoption of the mobile health app and your smartwatches is in fact, on an average, has a lot of positive effects. Number one, for patients of chronic disease symptoms, there's a drop in glucose levels, and that's really driven by a better diet, so fewer calories, more exercise time, and sort of longer sleeping hours. So all that is good. Good news, the other second good news is there's also a long-term benefit. So as you change your behavior, it's not just over the 15-month period. We're also seeing longer-term reduction in hospital visits and expenses. Mobile continues to have a much stronger effect than desktop. So, to the extent that we hope to see higher smartphone penetration in different parts of the world, that's also good news because this is likely to encourage more people to engage in this behavior. And lastly, personalization is basically a double-edged sword. Okay, in the short run, we do see some surprising effects, and people complain about judgment and annoyance. However, in the long run, it does show a positive effect in reducing hospital visits. And when we try to dig underneath the surface, then in the long run, there is a different element of trust that people seem to develop with the platform. Okay? So there's like a double-edged sword in the short run versus the long run. All right, so just to quickly, other ongoing work, we're looking at gamification. As in this case, in this experiment, right, the incentive for people to participate was $1 a lottery. So we asked people, anybody who's enrolled in the experiment, you're eligible for a lottery between $100 and $500. But next thing we're doing is we're avoiding the monetary incentive and looking at gamification. Second, we're looking at mental health outcomes as well, right? So this is entirely focused on chronic diseases and sort of physiological aspects. But especially after COVID, we all recognize, the importance of mental health. So we're looking at that as well. And lastly, we are, given the surprising result of personalization, we're looking at different sort of creatives and nudges too. Okay. All right, so that's pretty much all I had to say. Barbara has a question. Go ahead.
So were the nudges all negative? Because I wear this stuff, I get nudges all the time, but they're usually positive. So they told me I had a good day yesterday, and I had another good day today.
Yeah. No, so
that would be a different result. That could be regression to the mean or also.
Right. We did have both. We did have, so people who were actually complying, we would send them a positive nudge as well, and the ones who didn't would send them a negative nudge. So, there is a somewhat of a difference in terms of more complying with positive nudge and less with negative, but it's asymmetric. So the positive effect of a positive nudge is much smaller compared to the negative effect of a negative nudge. So yeah, we had.
There seems to be a conclusion there.
Yeah, I think that's what we're trying to explore more. Maybe there is the change in the messaging frequency. Maybe it's not every day, maybe once a week. So right now we're looking at some of these aspects and see, maybe there's something over there.
One more question.
I was just going to ask about personalization too, because I don't think it's the personalization. I think it's entirely the contextual, the semantics in the messaging. But I'm curious so this was done in China?
Yes, there is. Yes.
I mean, there's a pretty significant cultural differentiation, and in so many technology implications there that it would be. I assume it's going to be very dependent on the geographic messaging. Like in China, even like the stereoscopic technique was completely not accepted simply because of the small spaces, and people felt very intruded upon about something like that.
Yeah. So.
Where else it was
So I think, in the world of, so not in our study, but in sort of in marketing, people have contrasted some of these cultural aspects of personalization. In business, at least, there's no qualitative difference in the behavior. So whether you look at people in Asia or in Europe or in the US with respect to personalization, there's some quantitative differences, but people are still positively responding to it. So that's, at least what from the business aspects, we know that the positive effect of personalization continues to be pretty, ubiquitous. The only difference is in the extent of the positivity.
Okay, we probably should move on. I think the general topic of they're going to be taken around for a breakout discussion. I think that the topic of their thing probably most logically going to be that that AI can have enormous powers to really enhance people's well-being, but the boundaries for that or how do you do it are often not all that obvious, and there's you get surprising results. So hopefully that'll be for those of you interested, you can continue on that discussion.